It's such an honor to be here. Thank you so much to Simona and Francesca and the Italian Col4A1, Col4A2 Foundation for having me here. I'm really excited to talk about my experiences over the past year as we've started a clinic dedicated specifically to patients with Col4A1 and Col4A2 variants. As we said, I'm at University of California, San Francisco, and I'm a pediatric vascular neurologist and have had quite an interest in this condition for a number of years now after, first because of patients that I was seeing, and then specifically after I had gone through my vascular neurology training, realized that this is really a patient population with probably more prevalent than we realize, and also with a lot of questions about their management that really brought me into the field of something that I wanted to explore further. So for those of you who aren't familiar with where UCSF or University of California, San Francisco is, we are in San Francisco, so on the West Coast in the United States, and here's our lovely hospital. So who is part of this clinic? Obviously, Doug Gould, who is a researcher and collaborator at UCSF. He is fundamental to the work that we do. I also work with Dr. De Alba Campomanes, who is a pediatric ophthalmologist with a particular interest in genetic conditions that affect the eye and eye development, myself, and then Dr. Fay, who is a pediatric neurologist who has a focus in neuromuscular conditions and neurogenetics. And then I am proud that we have an adult colleague, Dr. Sri Krishnan, who's a vascular neurologist who is interested in monogenic conditions that cause cerebrovascular disease in adults. And we have several other colleagues that we work with in other fields beyond just neurology and ophthalmology, but these are kind of the core members of our clinic. So developing the clinic was, I share this just hopefully to inspire people around the world, to start developing their own clinics, and I just want to share kind of some of the thought process that went into this. So, of course, number one are the patients. So who are the patients that we want to be seeing in this clinic? And as a pediatric neurologist, of course, I generally see children, but of course we know that there's people of all ages that are affected by this. And so eventually, making sure that the clinic can take care of both children and adults is really important. And then clinicians, so who are the right clinicians to have in the clinic? And we started with neurology and ophthalmology, but of course are continuing to kind of expand and identify other specialists who really have an interest in this condition and who can become our local experts in other systems such as the kidney or the GI system and how that might be impacted in Col4A1 and 2. So, as I mentioned, kind of what other subspecialties to make sure we include is important. Another thing that we thought a lot about and still continue to discuss are kind of the pros and cons of doing in-person visits versus telehealth visits. There are benefits to both. Of course, in-person is usually a bit more personable and lovely to be able to, meet the families, examine the individuals in person. On the flip side, of course, when you're working with patients with rare diseases, they often are spread out across the country and world. And so, in addition, of course, a subset of patients with Col4A1 and 2 have pretty substantial physical disabilities, which might make it harder for them to travel far. And so, in addition to also financial constraints, there's definitely benefits to having a telehealth option, especially because a lot of the goals of our clinic were mainly about kind of disseminating information about this condition. And a lot of, I think, what we try to accomplish in the clinic can be done virtually over telehealth. So what were our main goals? So of course, patient-centered care, and the patients are at the center of this, and we always want to be designing our research, designing our clinics to be really trying to meet the needs of the patients that we are seeing. Access to experts. Obviously, when someone has a rare condition, it's really hard when all of your doctors have never even heard of this genetic condition. And so we really wanted to be a center where patients could come and be seeing clinicians who have heard of this condition, not just heard of it, but actually have seen a lot of patients with it, so that they can feel like they're actually getting advice that's specific to the condition itself. Collaboration with a local care team. So we don't attempt to be the primary source of care for most of our patients who are traveling from far away. Of course, we have a subset who are located close enough that we can be their primary care team, but I think the goal of the clinic when we designed it was really to be kind of serve a consultative role, so that patients could see us once or maybe a few times over the course of a few years, to help disseminate any updates in the field and help give recommendations for their care that could then be implemented by their local team. And then, of course, as part of the goals of the clinic is just, of course, thinking ahead and how can we expand our understanding of COL4A1 and 2 with any rare disease. I think that the clinical care is so closely linked to the research, and so really trying to inform our research based on each and every one of our clinical encounters is really important. So what does a clinic visit look like at the Gould Syndrome Clinic? So before the visit, we always try to review the medical records, of course. Often our patients have a lot of medical records to review, so certainly it's not always going to be a comprehensive review of every record, but at least I try to look through the most recent neurology notes, genetics notes, ophthalmology notes, etc. So then during the clinic visit itself, I always like to start by really trying to understand from the patient and or the family what their main goals are. We have about an hour together usually, and so there's a lot to cover in relation to usually the patient's medical history as well as our understanding of COL4A. But so I always like to kind of focus on exactly what the families are really looking for in the visit. Of course, then I go through what are the key details of their medical history. I try not to make people have to repeat every detailed, account of what happened from in utero all the way up to however old they are, but just I like to ask about certain key parts of their history. Then I go through a comprehensive review of all the different potential systems affected. I am a neurologist, so I tend to focus on the neurology aspects, but then, of course, we know that there's a lot of other organ systems that are affected. So especially in our further detailing of how this affects every organ in the body potentially, I think it's really important to be asking about any potential relevant symptoms. For in-person visits, we of course do a physical exam, and I try to document that in a very standardized way so that for our research, we will be able to go back and collect that information. And then I usually discuss kind of the general recommendations based on what we know now from the research that many of you in the room have published in our roundtable, always trying to share, what is our current in 2025 understanding of how to best manage these patients. And then, of course, talking specifically for the individual, what are the recommendations that we have about changes to their care plan relevant to COL4A1 or 2 that might be useful. I will refer to additional specialists. So again, usually the visit starts off with just seeing me, potentially also our pediatric ophthalmologist, but then if there are other areas that I've identified during the visit that could be addressed by another specialist, such as a nephrologist, kidney specialist, then I'll make sure that they have a referral to that specialty. And then lastly, I always invite patients to participate in our natural history study, which I will talk more about in a moment. I always view the clinic visit as kind of a two-directional experience. So of course, as the clinician, I want to help provide information to the patients, but I also view it as really a learning opportunity for myself. And patients and their families are really the experts, and we are learning from them. And so I always am honest about that and say, there's we know some about this condition. We still are learning every day about this condition, and so I want to learn from you, the patient, what your experience has been from your condition, living with this condition. That's a very important aspect to me. And then, of course, after the visit, we share our notes with their local treating physicians. And I think that is a really critical part of this too, because oftentimes I hear that the patients coming from a facility where their primary care doctor and even their specialists also have never heard of this condition. And so just as much as it's important to educate the patient, I think educating the local clinicians about this condition is super important, both so they can feel more comfortable, hopefully, treating the patient, and then potentially also recognize other patients in the future that might also have this condition. So now I'll share with you some of our preliminary data from the patients that we have seen. So I'm proud to say that we have seen 20 patients in, I think, about 9 months or so since officially opening the clinic. And so there's 20 patients from 18 families, and the ages of these patients were anywhere from 11 months of age to 25 years old, so with a median age of 11.5. We were equally split on male and female, and we had 2 sibling pairs. You'll see that looking at kind of the inheritance pattern of the variants of the patients we've seen, majority were inherited, a quarter de novo, and then there was a subset of unknown inheritance, usually because either the bio parents weren't available and or had not yet been tested. And then looking at the variant type, we had 70% with COL4A1 variants and 30% with COL4A2, which is a little bit higher percentage of COL4A2 than we see generally in the larger populations. I don't really know why this is, but just so happens. So where have these patients come from so far? So the majority of our patients have been from California, 15 out of 20 of them. That being said, California is very large. So actually, I'd say about half of those patients come from Southern California, which is 6-7 hours away. 1 from Washington, 2 patients from Texas, and one from Massachusetts, and 1 from Minnesota. So have a pretty good spread from all over the United States. We have also been, I know Doug Gould gets contacted by people all over the world often, and since opening the clinic, I think that we've had even more patients potentially reaching out, and have had patients contact us from the UK, from Turkey, from Australia and Brazil. And unfortunately, it can be hard to figure out ways to just to provide medical care across international borders, so we have not yet had a patient travel internationally to come see us. But it's something that we always evaluate on a case-by-case basis. So looking at the clinical symptoms in the patients that we've seen, I'll first start out by the neurologic symptoms. I would say that probably the patient cohort is somewhat biased towards patients who have neurologic manifestations, in particular because I am a pediatric neurologist. And I also will say, of course, this is only 20 patients, so I can't say that this is specifically representative of like the COL4A1 and 2 population as a whole. But I think it's interesting just to look at this data. So of the 20 patients, 60% of them had a stroke at some point, either clinically or more commonly based on neuroimaging. So 11 of the 12 of those were in utero or perinatal, presumed perinatal strokes. And 1 of them had a stroke that occurred at age 18, so kind of a childhood young adult stroke. And of all 20 patients, there's no one who has had a known recurrent stroke, which is an important thing to note, which is a question that often comes up. 15 out of 20 have a diagnosis of cerebral palsy. I'd say the majority of those patients are ambulatory, have a GMFCS type 1 or 2, so on the milder end of the spectrum of cerebral palsy, but a few that are non-ambulatory or have GMFCS 4 or 5. Epilepsy is common, as we know and heard earlier today, with 11 out of 20 with a diagnosis of epilepsy. Only 4 had infantile spasms or West's syndrome. And then looking at kind of developmental diagnoses, so all patients had some form of developmental delay and or differences. I included things like autism in that count. 4 have autism, including a few who only have autism as their only symptom, actually, of coli 1 and 2, which is interesting, without any structural brain differences. And then other common neurologic concerns that arise in this patient population are ADHD, mood disorders, headache, sleep disturbances. Here are a few examples of neuroimaging from our cohort. So just to give some examples of brain injury that has occurred potentially at different time points across the lifespan. These are not the same patient. These are 3 different patients. But this is a patient who had clearly had a fetal ICH, had multifocal hemorrhage, as well as had porencephaly. That obviously, so this was, I think, obtained at 2 days of life. So evidence, obviously, of significant encephalomalacia, had clearly had a hemorrhage quite a bit earlier on. The middle patient is a patient who has a presumed perinatal ICH. So this is the type of patient where there's no known complications until they kind of develop a handedness and get diagnosed with cerebral palsy and or might have epilepsy. And in this patient, in getting imaging at 18 months of life, saw that there was this small area of periventricular porencephaly, as well as you can see bilateral white matter abnormalities, and had a VUS in coli 1. And then the third patient is the patient that I mentioned earlier who had the stroke at age 18, so was a relatively healthy, otherwise adolescent, had some mild developmental differences and had febrile seizures as a child, but then at age 18 had a spontaneous intracranial hemorrhage in the right caudate, and underwent an extremely exhaustive workup for that at the time that was unrevealing, including things like a brain biopsy was performed, still not diagnosed with coli 1 until we did genetic testing. So thinking about symptoms in our patients beyond just their neurologic symptoms, so of course, many of our patients had eye abnormalities, so 70% had any type of eye abnormality. There was a subset that only needed vision correction and didn't have other like structural eye differences per se, but then half of our patients had other eye abnormalities, cataracts, retinal hemorrhage, cortical visual impairment, strabismus, et cetera. So certainly, as we all know, a wide array of potential ophthalmologic concerns. Something that I really want to highlight is the relative prevalence of GI and pulmonary complaints in these patients. I think it's something that is not really been well documented in cohorts in the past, and I think I am hopeful that by sharing this information, we as a community can put more resources into this. So gastrointestinal dysmotility is a very common concern, and sometimes is like the most the day-to-day most challenging symptom for some of these patients to deal with. So things anywhere from, constipation that can be relatively mild to all the way to gastroparesis and, really severe GI dysfunction. And then also interestingly, obstructive sleep apnea is pretty prevalent in at least the 20 patients that I've seen, with 8 patients having a diagnosis of OSA, although a subset of those grew out of it, interestingly. So just to highlight that. And then interestingly, in the patients that I have seen, again, might not be a totally representative sample, but there have been very few cardiac or renal complications. Not all of them had undergone extensive workups for cardiac abnormalities or kidney abnormalities, but at least some of them had. And then on symptom review, these didn't tend to be areas of concern. And then similarly, muscle pains or muscle concerns was not something that really came up in a lot of these patients. But again, I think that we probably aren't seeing the HANAC variety quite as much because I'm more seeing patients in a neurology clinic as opposed to, a renal clinic. So just to summarize, some common themes that have come up over, this past year of working with these patients, and of course, connecting with patients outside of the formal clinic setting, but just talking to a lot of patients from all over the world with COL4A1 and 2. So I'll start just by, again, kind of highlighting the significant GI issues that come up. And I always feel bad when a patient comes to me and, wants advice about COL4A1 and 2, and their main concern is, well, how do I deal with this really severe gastroparesis, dysmotility? Like, none of my doctors really know what to do. And I don't feel like I have good answers because I'm a neurologist, but I do think that it's, it comes up frequently enough that I do believe that there probably is some COL4A1 and 2 specific issues that are affecting like the smooth muscle in the gut causing this, but I am hopeful that the community can put more resources into studying this and hopefully partner with some GI doctors who can help us think through this more. And I'd be curious if there's anyone here also who has more to say about that. Other themes. So, of course, a very common question that I get asked is, what is my child's risk of having a recurrent stroke? And we don't have good answers to that. I think it is, of course, a very scary thing to think about. And I will say in my experience, again, in the clinic and reviewing many, many patients' records, it seems quite rare, but it's not a 0% risk. But I do hope that we can get better answers than just that. Every patient, of course, wants to know what is the long-term prognosis, and we don't have good answers to that. I think that's one of the many reasons it's going to be important for us to follow patients longitudinally in natural history studies. And then another question that always comes up is, of course, preventative care. What can I do for myself or for my child to help prevent the potential complications? And for right now, I think one of the main and only things that we have to offer is, really emphasizing the importance of good cardiovascular, cerebrovascular health, avoiding hypertension, avoiding other things that affect the blood vessels like diabetes, smoking, eating healthy, doing exercise. But apart from that, I think, unfortunately, we don't yet have disease-modifying treatments that can really prevent the longer-term complications that we suspect affect at least a subset of these patients. Another question that often comes up, especially when I see a child, usually like the index child who got the diagnosis, if we find out that it's an inherited variant, there might be a parent who has, of course, gone multiple decades of their life without knowing that they were a carrier for this. And often they say, well, I don't have any symptoms. What does this mean to me? And it's in some ways, those are almost the hardest patients to counsel because you have no symptoms, but we don't know that they won't develop symptoms. I also put the word asymptomatic in quotes because I think that a lot of patients say, well, I'm asymptomatic, but then once they go see a neurologist or really dive into it, they start to realize, oh, maybe I do have some subtle cognitive differences that might be relevant or might not be. But I do wonder about how asymptomatic are asymptomatic individuals truly. And I believe there might be some that are totally asymptomatic. So anyways, more to be studied about that, I think, especially because our literature is probably biased towards the more severe end of the spectrum. Of course, those are the patients who have been primarily being offered testing. But I think as access to genetic testing has become more prevalent, we're probably picking up on more asymptomatic patients. And it's equally as important to kind of chronicle their trajectory, I would say, as it is to look at the more severely affected patients. Of course, as many of you know, often these patients have had a long diagnostic journey. I will say that my experience has been the younger patients now, under the age of 5 have tended to have a pretty quick time to diagnosis, whereas the teens and older have often gone through years of testing. So I'm hopeful that, with the access to genetic testing, the time to diagnosis is getting shorter. Complex care coordination is a huge topic that comes up and, is not unique to COL4A1 and 2, but I think children with genetic conditions or physical and mental disabilities often face this where they have, a team of 8-10 doctors, and it's so hard to get them all to collaborate. And sometimes our visits actually kind of become mostly about how to really arrange a good care team, and kind of giving advice about that almost more so than about Cool 4A1 and 2. But at the end of the day, having a good functioning team of doctors that communicate with each other, I'd say, is so critical to these patients' kind of day-to-day function and quality of life. And then lastly, you know, I really just want to highlight that it's been very rewarding for me to hear all of the positive feedback that has come out of this clinic, patients expressing gratitude and hope, and really, you know, excitement about the future as more clinicians are identifying this condition, and also just feeling, the patients feeling so grateful that they finally meet a doctor who has heard of this condition. So, you know, even though I sometimes, I think, feel bad that I don't have more to offer in terms of therapeutics at this stage, I think that, I know, we are actually able to offer quite a lot just by being someone who has, you know, seen this condition, seen other patients with this. And I think that the families really can benefit from even just that, meeting someone who has seen another patient before with Cool 4A1 and 2. So what were some of the challenges? Of course, there are many. I think geographic diversity is a challenge with any rare disease, but really trying to figure out how to meet the needs of this population all over the world while only being physically in one place. You know, in the United States, unfortunately, we have to deal with insurance, medical insurance, and that can be a challenge, especially for seeing patients out of state. We usually can only see patients with private insurance across state lines, but not public insurance, and that really feels unfair to me because I believe in being able to provide care to people regardless of their ability to pay, but the reality is unfortunately that's not quite how our medical system works. Expectation setting, I think, is important and challenging. You know, patients will come to us very hopeful that we do have a treatment to offer, and so I always like to be very upfront. You know, we don't have a drug that can treat this or prevent complications yet, but hopefully, and then also just really providing the expectation that for the majority of these patients, I can't be their medical home, but I can help communicate with their local medical home and hopefully work with their local clinicians to feel comfortable in taking care of the specific complications of this condition. And then just figuring out kind of workflow integration, you know, how to build a clinic like this that fits with my other patients' needs, how to integrate the other specialists without, most effectively. You know, ideally, I think we have thought about a model where there were all the different subspecialists in one place all at the same time, which has some, you know, potential benefits. But on the flip side, especially with a condition where there's such heterogeneous symptoms, it's not very efficient to have, you know, a nephrologist there if they're only going to be seeing one of the 5 patients who comes that day. And so I think that also from a patient perspective, sometimes having too many appointments all in one day can be a little bit overwhelming. But we try to work with the patient and figure out exactly what their needs are and try to coordinate visits all together if possible. So next steps of our clinic. So as part of our clinic, as well as our natural history study that I'll mention in a moment, again, we are hoping to, you know, start in a systematic way collecting biospecimens, primarily in the form of blood, both to better understand, are there some biomarkers through the you know, serum that might be predictive of disease progression that could help us as we are working to develop therapeutics. And then additionally, iPS cell creation, so induced pluripotent stem cells. Actually, we have the for a subset of our patients who have enrolled in our natural history study, we have their consent to, with their blood specimen, use it to create stem cells and help make neurovascular organoids to better look at the exact effect on the blood vessels of the specific variant in a in vitro model. And then, of course, as we look towards the future, we're hoping to continue to bring more patients to our clinic, and as well as recruit our patients to our natural history registry. As I mentioned, kind of further exploring some of the other complications beyond just the neurologic, ophthalmologic, cardiac, renal conditions. I think that really we don't know much about the GI and pulmonary effects. Anesthesia is a topic that comes up, and I sometimes explore with my patients whether there's adverse reactions to certain anesthetics. I think is something that has come out of the patient experiences that we really need to do a better job of studying. Also understanding how pregnancy in mothers or fetuses with COL4A1 or 2 might be affected is an area that we definitely need to study further. And then I'll also say, ongoing collaboration with Mass General. Dr. Mussolino and her team is because the United States is obviously so big, we're trying to work to establish centers in a variety of geographic locations so that patients can travel more locally to see an expert than having to come across the country. And so it's been wonderful to have certain providers from around the United States reach out with patients who they have questions about, but then when they express an interest in this condition, we're trying to encourage other clinicians to become their local experts as well if they have seen a few patients. And then, just as Diana did earlier, I just wanted to highlight our natural history registry. I will say we are working together, so they are part of kind of one larger project, but we invite patients from all over the world to reach out if they're interested in enrolling in our natural history study, which is looking at both adult and pediatric patients, including asymptomatic individuals. We've so far recruited 29 individuals, which is exciting, and then have a goal of recruiting probably 100 to 200 individuals with COL4A1 or 2 variants. Does not have to be labeled as pathogenic. Obviously wanting to also look at the VUS patients. And our goal is that we will be following patients over the course of about 10 years to look at, prospective longitudinal progression or lack of progression of their conditions. And we can enroll remotely. So patients don't need to come to our center in San Francisco to be part of this study. They can submit their medical records, and we can help review their medical records remotely. And then, of course, as the Render group had talked about as well, super important to our natural history study is also collecting quality of life metrics, patient-reported outcomes. And so we have been using the PROMIS scale, which is a validated tool from the NIH that helps to quantify kind of how patients feel their day-to-day function is. Just briefly, from our natural history registry, part of the patient-facing questionnaires include kind of a list of research priorities and clinical priorities for our patient cohort. And this is only based on 14 patients so far, but I just wanted to highlight in order of most to least important of the options that we gave them, kind of what are the priorities. So number one is disease-specific therapies and interventions. And I'm sure that doesn't come as too much of a surprise to everyone in this room. Our eventual goal is how can we help these patients? How can we prevent progression of the condition? After that, of course, better understanding the disease is important, improved access to testing and counseling, and then improved awareness by medical providers. And even though, it's maybe the fourth, I don't want to imply that it's not important, but I just thought it was interesting to see kind of the patient's ranked order of these 4 things. And I don't know how, hopefully you can see this. Just wanted to include patient voices at the end of this, just to highlight again, as I said, I think the patients are at the core of all of our work on this, both in our clinical work and our research. And I think that we need to continue to use kind of their goals in directing our research and our future directions. And so I think the themes that I have already talked about in the talk are highlighted here, just that patients are hoping for preventative care, treatments, thinking about kind of their cognitive care, aging, all of those things. And I hope that, we can use some of these quotes as motivation as we continue our work. And thank you so much. I hope I have inspired some of the people in the audience to build your own clinics for Col4A 1 and 2 patients.
Thank you so much. There's a question. Thank you for sharing your experience and for show how big is the work before and after the clinical visit with the patients. It's a very big work.
Thank you so much. It was a beautiful presentation, and it really highlights how we should move towards a more and more multidisciplinary assessment of this complex patient. So I fully agree with this approach and this type of clinic setting. I just wanted to share about the gastrointestinal finding, because we also have a few patients having the same complaints, and there is nothing in the literature, but of course I think it's it could be related because, of course, I mean, in the bowel there is collagen. So I wonder whether we should think, I don't know if that has been explored in the models, but it is definitely a complaint from patients. It's, as usual, differing in terms of severity, but it's probably something should be explored, and perhaps you are also including that in your natural history study.
Yes, I totally agree. And yes, we are asking about gastrointestinal symptoms as part of our natural history study, as well as it looks like the Render database is, looking in depth at that as well. But yeah, I think that we probably need to bring into the network, some GI specific doctors, because I can, come up with questions that I think are important, but as not a GI expert, I don't know that I have the exact right questions to be asking patients about the severity of their GI symptoms.
Sorry, building up on this question, have you seen any correlation with the degree of, the severity of the disability? Because very often, disability is connected with gastrointestinal symptoms, because like walking deficiency and all this stuff that is correlated with motility of the intestine.
Yes, I totally agree. And I think it is hard to disentangle how much of the GI symptoms are related to the cerebral palsy, potentially, because of course our CP patients often experience a lot of GI issues. But I would say that so sometimes there's a correlation, and I would say it is maybe more related to the degree of disability, physical disability. But we also see in patients who have very mild or even like no CP, I'd say a higher rate of reports of constipation or gastroparesis compared to what I would expect in my patients with mild CP who don't have Col4A. I feel like it's not an issue that comes up quite as much. But again, I think we don't really have good numbers to back this up, but this is just my anecdotal experience, and sounds like, I think others have observed similar things.
But I agree also, in my experience, is not necessarily linked with the degree of neurological impairment. So, it's very interesting. Again, I think I'm not sure how is the expression in the GI system. Probably we should look at that, and I don't know if there are different sort of composition of the bowel that may affect the presentation as well. So I don't know.